Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk about 3 articles from the journal that have recently been published online, and the theme for the month is technology.
Another themed episode.
Yes, we're into themes these days. Themes better than random. So, we'll hopefully, maybe you guys can give us some feedback about whether you like the themes.
Or suggest a new one.
There we go. So anyway, the theme is technology, and we're going to be talking about one article that focuses on text messaging to detect postpartum depression, another article that will focus on using telemedicine to promote medication adherence, and then we're going to conclude with a paper that discusses ethical considerations for psychiatrists and mental health clinicians in doing internet searches on their patients.
Should be a good one.
Yeah. Okay, here we go.
First up, we have Andrea Lawson and colleagues on the use of text messaging for postpartum depression screening and information provision. So postpartum depression screening. Like a lot of things, if you don't screen for it, you don't find it. Only 18 to 25% of postpartum depression cases are found if you're not doing a screening.
And that's really important to note, that here's this huge problem that affects mothers, that affects their babies. And it's just, unless we actively seek it out and look for it, it will not come to our attention for the most part.
Yeah, and they're pointing to a lot of different barriers to why there isn't effective and widespread screening. So on the provider end, they're not always familiar with the tools. They have a hard time incorporating it into their regular routines. There's a lack of time and resources. On the other side, it's difficult for mothers to know if they're just experiencing kind of the regular baby blues or if this is something they should really be concerned about. There's a fear of having child protective services called, which is something that we addressed in one of our previous podcasts. And then, I'm not speaking from my own experience, but from what I can tell, it's very challenging to do things when you have a newborn child. I can barely get myself to go to a doctor's appointment with my schedule, let alone taking care of a small human.
Yeah. Well, and it, just speaking from some experience, even I, as a relatively well-resourced person, it's hard in the postpartum period. You're overwhelmed, and that being overwhelmed is normal. So we have a really, really challenging situation of a condition that's not easily detected, and there are a number of reasons for it.
So text messaging to the rescue basically has none of those issues that we just mentioned. It's cheap, it's widespread, it's been used successfully for other purposes in this very population, the peripartum population. And, you don't have to go to an appointment. You can just pull your phone out of your pocket.
And in fact, there are no previous reports on the use of text messaging for mental health screening in the perinatal population.
Right. And so this study is seeing if it's feasible to use a brief screening tool sent over text message to people to screen for postpartum depression. And in particular, it's looking to see how well a brief tool will compare with a gold standard screening. And then they're also sending out informational text 3 times a week. And they're also trying to find out how people experience this intervention. Do people who are getting screened think this is an effective way to screen? So on to a couple details. They approached 1,608 prepartum women in Toronto that they're recruiting from a hospital OB-GYN clinic. So after they're excluding people in active psychiatric care, got consent, they counted for dropouts, there were 937 women in the final sample. So I think that's 67%.
Yeah, they turned out they reported a 67% consent rate, which, again, to the extent that consent rate is very important to understand the representativeness of the population. It's not a bad consent rate. It'd be better if it were closer to 100%, but it's also not 25%. So, it's reasonably representative.
So what they're doing is, after these women have their child, they're sending them PHQ-2, which we'll explain in a second, via text message every 2 weeks for 12 weeks postpartum.
So that sounds like that would be 6.
Yes, 6 times that they're sending the PHQ-2. So what is the PHQ-2?
I just wanted to show off my mathematical prowess.
12 divided by
2
is 6.
6,
Great.
right.
We're having a good morning over here at Pages to Practice. So the PHQ-2, which people may be familiar from, it's the first 2 questions of the widely used screening tool, the PHQ-9. And so these first 2 questions are, how often have you felt down, depressed, or hopeless over the past 2 weeks? And how often have you had little pleasure in doing things over the past 2 weeks? And what people answer, they give an answer in a scale from 0 to 3. So 0 means I haven't experienced that symptom at all. 1 means on some of the days. 2 means
more than half of the days.
And then 3 is most of the days. So they're administering this PHQ-2, and then they're seeing how it compares, again, to this gold standard screening tool called the Edinburgh Postnatal Depression Scale.
Right.
How'd I do in my Edinburgh pronunciation?
Beautiful.
Thank you.
And I am, of course, a really good judge of that, being, growing up in New York without, with if anything, a New York accent.
Yeah, so our Scottish listeners can let us know how we're doing. And again, sending out informational text and doing a follow-up survey to see how people experience the intervention. So here's their results.
The first thing they did was they looked at their original cutoff for a positive screen was a score of 2, or more than half of the time for one of the symptoms.
Right.
Least. So if a woman responded, I feel depressed, more than half of the time, she screened in. If a woman reported that I don't have pleasure, more than half of the time, then she screened in.
Right. And so when they're using this...
Or both, actually. She could have said both, right?
Yes. But that's sort of the base value.
Right.
And so when they're using this cutoff, they're finding, and comparing it to the results of the gold standard Edinburgh, they're finding that the test has a sensitivity of 0.49 and a specificity of 0.93.
Okay.
So we want to just take a brief epi break and talk about sensitivity and specificity.
Right. So again, the sensitivity is the ability of the test to correctly identify those with the disease. In other words, the true positive rate. How many of the people who have the disease are being picked up? And whereas the specificity is the ability of the test to correctly identify those without the disease.
So let's go back to their initial results when they're using their cutoff of having more than half the days of the symptom on one of the 2 questions. The sensitivity is 0.49. That means that among all those women who actually have postpartum depression, it's only picking up about half of them.
Perfect.
And so that, for a screening tool, is
not so hot.
Yeah,
we want this tool, I think, to really identify women that have depression.
Yeah, and so what they did is they looked at the results with a lower cutoff, saying that you answered on several days for both of the questions at the very least.
Right. It's interesting because is it a lower threshold or is it a different threshold? Right?
It's a different threshold, and what they found is that you're going to pick up more people who actually have depression. So their sensitivity went up to 0.9. The drawback is that you're going to identify some people who don't actually have postpartum depression, and so their specificity actually goes down.
Yeah, the specificity was 0.82.
So again, this isn't just a study about the sensitivity and specificity of the screening tool. It's also if this is a feasible way to deliver the screening tool, and if it's something that people actually find helpful. And they found a really high response rate to the text messages. So for that first text at 2 weeks postpartum, they're getting a response rate of 99% of people are replying. And that drops off over the course of the study. But by the end of it, it's still pretty high. 92% of women are responding to that last text.
Yeah, that's impressive.
And the survey results also show that of the people who responded to the survey, which obviously isn't everybody in the study, a vast majority of them say that women in the postpartum stage should receive informational messages and would recommend screening over text messages as well.
They mention in the limitations that I think the ethnic and racial diversity of the sample and socioeconomic diversity is somewhat limited. So we have to kind of take that into consideration as well in terms of the general acceptance of this procedure. But it's still pretty impressive.
Yeah, it reminds me a little bit of the study we talked about a while back about sending postcards after somebody's presenting to the emergency room with suicidal thoughts or behavior. Just in terms of the simplicity of the intervention and the brevity and getting potentially a lot of bang for your buck here. And so I think the authors point out, and we would agree, that there's more work to be done, but it definitely shows that this is a feasible way of screening for postpartum depression. And there's just such a huge gap in that area that this seems like it's a huge step in the right direction.
Right. And again, as you say, Josh, there's a lot more to be done in this area, including then what happens next.
Right.
Once someone is identified, and that then, identifying people without having the strategy and a method to actually provide them with treatment and help, the job is not completely done.
But we can't do the job without the screening tool.
Yeah, exactly.
Next up, we have Laura Schultz and colleagues on improving medication adherence with telemedicine for adults with severe mental illness.
So we're going from text to telemedicine.
Yes, and they're also sneaking in a little bit of texting here as well.
There you
but
go.
We're trying to keep our
and we're going from Canada to Germany.
All right, we're bouncing around.
Yes.
So this is a brief report from Germany, and the authors had actually developed a phone and text telemedicine program for anxiety and mood, and now they're expanding their approach in a randomized controlled trial.
RCT. I love RCTs. I do.
You just looked sort of beatific.
Yeah.
It's just at the mention of the word.
Well, because internal validity. We love external validity, and we love internal validity.
So this study is making Lisa very happy.
Yes.
As a randomized control study trial for people with schizophrenia and bipolar disorder using phone calls to increase medication adherence. And it's a pretty basic outcome. They're seeing whether or not those in the intervention group have better medication adherence at 6 months than people in the care as usual group.
Right.
So they recruited 120 adults with schizophrenia and bipolar disorder from the inpatient unit or day programs from 3 psychiatric hospitals in Germany. They're excluding people without a phone. They're also excluding people not on medications. They're excluding people with suicidal tendencies, which is also going to point to the validity issues. And then also people with scheduled inpatient treatments over the following 6 months. And in a separate conversation, we would love to know what a scheduled inpatient treatment is over in Germany.
Yeah.
In any case, so they randomized the groups.
They actually randomized the individuals to the groups.
Another point well taken.
Sorry.
120 individuals, 2 groups. So both of these groups are following up after discharge with regular appointments. It wasn't really part of the intervention, like who they saw and how they followed up with their outpatient appointments. The intervention group, though, also gets a phone call from a nurse every other week for 6 months after discharge from the hospital. I'm waiting for you, dude.
I know. I want to show off my mathematical prowess again.
But we're not.
It's something like 12 calls.
I think it's also, it's 12.
Yeah, 6 times. We've already reviewed 12 divided. 6, 2, and 12 are related. Okay. Right.
So, all right. So the calls are really interesting, actually.
This is really important, really interesting.
Yeah, so they the calls open up with a check-in about major events and the person's mood. And then the second thing they talk about are personalized topics like hobbies, jobs, or family issues. So this is a less structured part of the interview where they're actually checking in about these individualized personal topics.
And about the person's life. Right.
And then they're moving on to standardized questions about medication adherence, side effects, barriers to adherence, and then another set of standardized questions about suicide, then a summary and planning for the next call. So they also offer the option of sending weekly text messages regarding a specific topic. So at 3 months and 6 months, they have the groups fill out the self-reported medication adherence report scale, and then they look to see if there's differences between the two groups. And so what they found is that at 6 months, the intervention group has 4.11 times the odds of being medication adherent than the control group. And that's after they control for age, sex, and baseline adherence. And they also tried to look at a couple other things. They were looking at a few other measures. So the number of medications, the specific diagnosis, and they also included a measure of social desirability.
Yeah, that was really interesting. And so social desirability being kind of exaggeration of positive qualities and minimization of negative qualities by the person.
Yeah, so they might say, oh, I've been more adherent to a medication because I want to please the examiners. But they put in a measure of that and they control for it. And so even when they look at these things, number of medications, diagnoses, social desirability, they're still finding, their findings basically don't change in terms of the medication adherence between the two groups. So one of the things that I think that one of the most interesting parts of this study was that the individualized section of the interview, I think, was something that I really wondered about how much of their results sort of stem from having, you're not just calling in and checking in about are you taking your medications, that you're actually developing a connection and talking about things that are important for the person,
right,
on the other end of the
line.
line.
So in other words, firstly, of course, it's impressive that they were able to demonstrate increased medication adherence, with all the limitations of the study in terms of reliance on self-report.
Yeah, and we also didn't mention that basically they define medication adherence as having like a perfect score on the scale, and so somebody who's kind of more in the middle in terms of their adherence would be scored as a no, that they're non-adherent. Right. So that their results might even be conservative.
I also was interested by the fact that the interaction, the scripted interaction, didn't just say, oh, pick up the phone and say, are you taking your meds? That it really, there was a structure that promoted, I think, engagement and dialogue. And, this person's interested in me. This, I like this. This is what I'm imagining, that in order to, that adherence in and of itself, independent of relationship, is not, you can't influence adherence just by focusing on it itself. What is about is I think, and I would guess, is the relationship with the person and building that trust.
It's engagement. It's also an interesting juxtaposition with the last article that we talked about and thinking about the differences between having a phone conversation and automated text messages, and whether or not there's some sort of the human connection that you get over the phone might produce different results, just in general, not even talking about these two particular studies, than you get over texts. And are the texts automated, or are the texts an actual person on the other side, or is there a way to incorporate something individual into text messaging as well that might kind of draw on these same issues?
I think that's a really interesting point. Yeah, a couple of other interesting aspects of the study, from my standpoint, are so that trained nurses actually did the calling, and so then I found myself saying, well, trained nurses are very expensive, and is it possible to do this with why nurses? I can understand some advantages of having nurses do it, but then I was wondering whether we could substitute or whether other individuals from other disciplines might be good at doing this as well.
A peer.
Right. Yeah. And then I also found myself wondering about how this intervention connected or didn't connect with the treatment.
So again, it seems like we're kind of opening the door and getting our first few steps in, but there's more to be done. Yeah,
and I think, again, both of these studies are showing some of the power of using technology, really in very simple ways, hopefully to help people do better.
Last up, we have Charles C. Dyke and colleagues on ethical considerations regarding internet searches for patient information. So no technology episode would be complete without the internet.
Right.
So this is actually a review from the APA Ethics Committee. And, when we talk about reviews and overviews, we want to point out a couple things. We think it's a really important topic and a very interesting issue. And actually, as the authors point out, this is what they're producing isn't necessarily a set of hard and fast guidelines, but they're really trying to spur some discussion about these issues and to have people sort of know what to think about when they're thinking about internet searches for their patients.
Well, and just stepping back for the moment, I as editor, I want the journal to be a home to these kinds of discussions that are really, really important for psychiatric services delivery. So this is, again, not technically a Prisma review of the topic, but it's a synthetic discussion based, from the APA Ethics Committee.
Yeah, and what they do in the article is they're basically laying out a couple of issues to be considered, and then they're making a couple of recommendations. So one of the issues is that it points out that you can't trust everything that you read on the internet, which is sort of...
Really? Oh,
who knew, right?
Right.
So if you are doing an internet search for whatever reason, you really have to take everything that the information you're getting with a real grain of salt. It does talk about a couple of potential benefits, and one of them is getting some collateral information that might otherwise be impossible to get when you're working directly with a patient. Another issue that they're bringing up that that's not sure I have thought about it in the past, because they're talking about using health information exchanges and prescription drug registries. And so... in New York, at least, we're required to check the prescription drug registry before we prescribe a controlled substance. So that seems pretty straightforward. But again, all these issues...
You have to do it.
You have to do it. Extremely straightforward.
Right.
But then I think there's, again, things get a little bit murky, right? So what if you have a patient who you suspect... So you're not actually prescribing a controlled substance, but you may suspect that they're getting an outside prescription, or you wonder about their drug use. Is that appropriate use of the prescription drug monitoring?
Yeah, so should you check their name in the registry, right?
Right, or as a matter of course for all intakes, because there's this huge amount of information out there that's not publicly, but available to you as the provider. So even the things that are very straightforward, I think, have these implications that are a little bit trickier. And then one of the things that I really like that they point out is that there's differing values about this issue, particularly in specific about whether or not to use internet searches for your patients, but I think more broadly about privacy and the internet in general. And I think some of that might be generational, and some of that might be individual to different people, how they think about their online information.
Yeah, and one of the follow-up points to that particular point, that people have different values, is the importance of talking about it with your patients or even with your colleagues. And don't make assumptions about people's values.
Yeah, one thing they mention, and also one thing that's come up for me in my clinical practice, is that some people want you or expect you to look up something that they've mentioned that's online. And I think that that's a perfect example of a time when it's really important to engage in a clinical conversation with the person about what they're expecting from that and why they want you to do it, and really explore it. So they also have a couple of key recommendations from their reviews. So the first one seems like relatively obvious. Just don't friend your patients on social media.
Even if they try to friend you. Right?
Well, that might be kind of an even more common situation is when they're seeking out information about you. Unless it's an emergency, you should get consent to do an internet search. And this sort of ties into one of their other recommendations, which is to really investigate why you're thinking about doing an internet search on a patient and what your motivations are, and that if you come up after this self-examination with curiosity as the answer, that's probably not a good reason to do an internet search.
Yeah, stop if you're saying, I'm just curious.
Right. Right. Or if you just have that feeling inside you, like, oh, I really want to know something about this. And then I think one of the kind of along those lines is also to consider the effect on the therapeutic relationship. How would an internet search, if you found out information about somebody, what would you do with it? And if you talked about it with them, how would that change things within the context of the relationship that you have with the patient?
And then I guess lastly, they talk about perhaps the unique situation of forensic evaluations when you really may have a situation where there's some danger or criminal types of information about criminal behaviors. And again, I think this would be where if I were doing a forensic evaluation, I would make sure I knew exactly what I was doing and why, and what I was hoping to find, and what the purpose of it is. Again, as they say, interpret information with caution.
Yeah. Well, it's another area that seems like it's pretty straightforward, but then there's also a lot of probably some issues kind of on the boundaries, right, where if you suspect somebody of having a forensic background, but they haven't told you about it, or you have reason to believe that they're not being truthful just in a basic psychiatric interview, do you then look up their if they have a criminal record on any of the resources available? So I think this is what I appreciate about the article, is that it really should be a jumping off point. And I don't think it's possible to come up with hard and fast recommendations that are going to apply in every setting. It's just too broad of an issue. Yeah,
and I would just say we've really not, in some ways, I really would recommend that you read the article, that our listeners read the article, because you're going to find the ways that it resonates with your work, and then really if there's you have further questions, then digging into the references of this piece, because I do think it's quite useful and it's quite thoughtful. Well, that's it for this month's podcast. We hoped you liked our 3. We hoped you liked our technology theme. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. And also, check out the Editor's Choice topic collections available now. This second round of the Editor's Choice collection is focused on recovery. You can sign up at appi.org/ETOCS. appi.org/ETOCS. We welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thanks for listening. We'll talk to you next time.
Bye-bye.